Hello, everybody. This is Fadila Shaib speaking to you from the Geneva WHO headquarters and welcoming you to our global COVID-19 press conference today, September 25th. On Monday, we briefed you about the COVAX facility, part of the COVAX, the vaccine pillar of the access to COVID-19 tools, known as ACT Accelerator. Today, we are launching the ACT Accelerator investment case. Before we go deep in developing this important aspect, Dr. Tedros, our Director General, will address you first. Joining Dr. Tedros in the room are Dr. Mike Ryan, Executive Director, Emergencies Program, Dr. Maria von Kerkhove, Technical Lead for COVID-19, Dr. Mariangela Simao, Assistant Director General, Access to Medicines and Health Products, Dr. Sumya Swaminathan, Chief Scientist, Dr. Bruce Aylward, Senior Advisor to the Director General, Lead ACT Accelerator. The briefing is being translated simultaneously into the 6 UN official languages, plus Portuguese and Hindi. Now, without further ado, I will hand over to Dr. Tedros for his opening remarks. Dr. Tedros, you have the floor.
Thank you. Thank you, Fadila. Good morning, good afternoon, and good evening. With the Northern Hemisphere flu season approaching and with cases and hospitalizations increasing, many countries find themselves struggling to strike the right balance between protecting public health, protecting personal liberty, and protecting their economies. So-called lockdowns and the impact on global travel and trade have already taken such a heavy toll. The global economy is expected to contract by trillions of US dollars this year. Many countries have poured money into domestic stimulus packages, but these investments will not on their own address the root cause of the economic crisis, which is the disease that paralyzes health systems, disrupts economies, and drives fear and uncertainty. We continue to urge countries to focus on 4 essential priorities. First, prevent amplifying events. Second, protect the vulnerable. Third, educate, empower, and enable communities to protect themselves and others using every tool at their disposal. And fourth, get the basics right. Find, isolate, test, and care for cases, and trace and quarantine their contacts. This is what works. Effective vaccines, diagnostics, and therapeutics will also be vital for ending the pandemic and accelerating the global recovery. But these life-saving tools will only be effective if they're available for the most vulnerable equitably and simultaneously in all countries. The Access to COVID-19 Tools Accelerator is the best bet for speeding up the development of the tools we need to save lives as fast as possible, and to make them available for as many as possible, as equitably as possible. Today, WHO and our partners are publishing a detailed strategic plan and investment case for the urgent scale-up phase of the ACT Accelerator, building on the success of the startup phase. The investment case illustrates some of the considerable economic benefits from accelerating the development and deployment of tools to rapidly reduce the risk of severe COVID-19 disease globally. By the end of next year, the ACT Accelerator aims to deliver 2 billion doses of vaccine, 245 million courses of treatment, and 500 million diagnostic tests to low and middle-income countries. Today's status report shows that in just 5 months, the ACT Accelerator has made remarkable progress. The diagnostics pillar is evaluating more than 50 tests, including rapid and accurate diagnostics, and we expect to have more news on that next week. The therapeutics pillar is analyzing more than 1,700 clinical trials for promising treatments and has secured courses of dexamethasone for up to 4.5 million patients in lower income countries, the only medicine shown to reduce the risk of death so far. And COVAX, the largest and most varied portfolio of COVID-19 vaccines globally, is supporting the development of 9 vaccines and with several more in the pipeline. The number of countries joining the COVAX facility grows every day. As of today, 67 high-income economies have formally joined, and another 34 are expected to sign. Joining 92 lower-income countries who are eligible for financial support through Gavi. Investing in COVAX increases the probability of being able to access the best vaccine and hedges the risk that countries that have entered into bilateral agreements end up with products that are not viable. The ACT Accelerator is an unprecedented global effort. Of course, realizing its vision needs investment. The current financing gap for ACT Accelerator stands at $35 billion. $35 billion is a lot of money, but in the context of arresting a global pandemic and supporting the global economy recovery, it's a bargain. To put it in perspective, $35 billion is less than 1% of what G20 governments have already committed to domestic economic stimulus packages. Or, to put it another way, it's roughly equivalent to what the world spends on cigarettes every 2 weeks. Of the $35 billion, $15 billion is needed immediately to fund research and development, scale up manufacturing, secure procurement, and strengthen delivery systems. Normally, these steps are done sequentially. We're doing them all at the same time, so that as soon as a product is ready to go, we can get it to the people who need it immediately. We're not asking for an act of charity. We're asking for an investment in the global recovery. The economic benefits from restoring international travel and trade alone would repay this investment very, very quickly. Next Wednesday, world leaders will meet virtually for a high-level side event during the United Nations General Assembly to discuss the work of the ACT Accelerator and to call for the financial commitments to realize its promise. The window of opportunity is now. We must act now and act together to end COVID-19. I thank you.
Thank you, Dr. Tedros, for your opening remarks. We will now open the floor to questions from journalists. I remind you that you need to raise your hand, use the raise your hand icon in order to get in the queue to ask your questions. I will now give the floor to Mr. Du Yong from Xinhua. Can you hear me?
Okay. I can hear
Mr.
you.
Young, or?
Can you hear me?
Yes, I can hear you. Please go ahead.
Okay. Thank you for taking my question. Many world leaders expressed support for multilateralism at the UNGA. The Chinese president has also reaffirmed the commitment to multilateralism and stressed that solidarity and cooperation is the most powerful weapon in the face of COVID-19. So how will the WHO continue to utilize multilateralism to beat the pandemic? Thank you.
Thank you, Mr. Young. I would like to give the floor to Dr. Ryan.
The World Health Organization was actually created as a multilateral institution by 194 member states. It owes its very existence to the idea of multilateralism, sharing of knowledge, collective responsibility for global health, and collective action to protect it. The work that we do today in every aspect of this response, the work that the partners in the ACT Accelerator are doing around the world speaks to that mandate, it speaks to that responsibility, and one which we take very seriously. And therefore, yes, of course, this is a time that the Director General's speeches time after time. He's been calling since January, February for solidarity, science and solutions. And the ultimate expression of solidarity is governments acting together collectively and in a coordinated fashion to solve problems for all our citizens. And we very much welcome all of the commitments to that we've seen at the UN General Assembly from many, many countries over the last week.
Thank you, Dr. Ryan. We will move now to London, to Mr. Borzu Daragahi from The Independent. Can you hear me? Please unmute yourself.
Hi, can you hear me?
Yes, very well. Go ahead, please.
Great, I'm actually in Istanbul. I had a rather broad question about the impact of the COVID-19 pandemic on global medicine. Can any or all of you, if you would like, comment on how the pandemic, in your view, over the last 7-8 months has changed medicine in terms of recruitment, retirement, protocols, and what, if any, patterns have you seen within the medical communities regarding changes? Amnesty said earlier this month that at least 7,000 medical workers have died of COVID-19. I don't know if that's a total number, but how does a tragedy like that impact a profession as medical professionals yourselves?
Thank you. To respond to your question about the impact on health workers, I would like to give the floor to Dr. Edward Kelly, who is Director, Integrated Health Services at WHO. Dr. Kelly, you have the floor.
Thanks for the question. And the bottom line is that COVID has changed probably forever many things in our societies, but certainly it's changed the delivery of health services. Just last week with Dr. Tedros and a number of people here in the room, we celebrated World Patient Safety Day, the theme being safe health workers, safe patients, to talk about the impact of COVID and not just infections, but the stress and the mental health and also the new ways of working that have forced the medical community to adjust to COVID. Right now, in terms of what's reported to WHO, the healthcare workers in terms of infections have been about 14% of all the infections that are reported to us. There's limited data on this, but I think it's highlighted that we need to study more, and it's certainly put the spotlight on the fact that reforming and supporting health workers in all aspects, and we're talking about not just care deliverers, but the people who clean the rooms, the people who work in the community, in terms of outreach workers, have been majorly impacted. WHO's done a number of studies on this, looking at the essential health services and the continuity of those health services. There's been an impact across the board in terms of health services. About half of all health services at one point were interrupted, but it's everything from things that can be managed at some way, like dental services and rehab services, down to acute emergency services. So all countries right now are figuring out ways to make this work. WHO is trying to gather some of those experiences and share them as part of the response, and this will be something that we'll be working on with countries going forward.
Thank you, Dr. Kelly. I think Dr. Maria von Kerkhove has something to add.
Yes, thank you. I'd like to address the first part of the question that you asked about the bringing together of the medicine and how has that changed. I think one of the things we've seen, and WHO does a lot of work in this area of convening the world's scientific expertise and the world's leading experts on any number of topics that we are working on and responsible for. And this pandemic is no different. So quickly we utilized our networks that have been in existence for emerging infectious pathogens like SARS, like MERS, like influenza, and brought that together to better understand what we were learning about this virus, around severity, around transmission, about clinical care, about everything that you could think of. And that was no different in this pandemic. But what that really allowed us to be able to do, and you've heard me say this before, we are working with thousands of scientists all over the world and all of these different international networks. But that really helped us to be strategic and smart about the type of studies that needed to be done. We had a meeting in early February under the R&D blueprint to have a research forum to say what are the critical questions, the critical unknowns that need to be addressed under 9 different topics, from epidemiology to the animal-human interface to therapeutics to virology, all IPC, so many different topics, and then pushed that science to be done, pushed those studies to be done, ensured that we had the right groups doing different types of research and not all doing the same research in one particular area, and then coming together regularly to discuss and debate, review all of the papers that are coming out. And I think that ability to be able to harness that world's expertise, not only to say these are the studies that need to be done, but to drive all the way through identifying the priorities, outlining the research methodologies that are critical to address those critical unknowns. And we have a number of protocols that are out to follow really high-level, robust methodology, everything from zero-epi through the clinical trials, to be able to get those answers quicker. But the science is really accelerating. I mean, 9 months, 10 months in, the science is coming fast and furious. And we work through our science division that Sumya leads, and with our partners and in the science division, but also the Goran Research Network, to review the studies that are coming out every day. And there are preprints that come out every day. They haven't gone through peer review, but there's hundreds of them, if not thousands of them. And the studies are becoming sharper. The studies are becoming more specific. They still need to go through peer review so that they go through that process. But we are working to pull all of that together and look at our guidance and look at our advice. And that's why our guidance and advice evolves. But I think that's a really good question, because this pandemic, again, just accelerates the speed at which WHO and our partners are able to come together and push that even further. So it's a process. Science never finishes. It's something that evolves over time and it grows, and that's a positive thing, and that's why our guidance evolves over time. But we're really grateful for all of our partners doing high-quality research, taking the time to do it well, putting it through peer review, and making sure that they're addressing these critical unknowns.
Thank you, Dr. Van Kerkhove. Now the next question will come from Stephanie Nebehe, Reuters. Stephanie, do you hear me?
Yes, thank you, Fadela. Can you hear me?
Yeah, very well. Go ahead, please.
Thank you very much. I wondered if someone could elaborate, please, in terms of what I understood were the 67 countries that have joined, self-financing countries that have joined COVAX, with, I think you said 34 more expected. Could you elaborate as to whether China is among those, and whether Taiwan, which today said it had signed up on September 18th, is among those? And also, just as a corollary, we understand from a Chinese official today that WHO has, quote, supported its emergency use of vaccines. Can you perhaps comment on that, please? Thank you.
Thank you, Stephanie. Dr. Bruce Aylward.
Thanks, Fadela. Yes, so that's correct. Right now, there are an extraordinary number, and it changes every single day in terms of the number of countries that are working with with the countries and economies working with the COVAX facility. As of today, as the Director General mentioned, it's 159 countries that have already confirmed, countries and economies, that they are going to be part of the COVAX facility. Of these, we've got 92 are what we call AMC eligible countries for support, and then we have the 67 what we call self-financing countries and economies. And of those, we have 29 actually have come together through what's called Team Europe, and in addition there's another 34 that are still in discussion. So the final number could be well over 170 countries and economies that are part of this. And yes, indeed, Taiwan is one of the economies that have joined the COVAX facility, and which is great. We're in discussion with China as well about the role that they may play as we go forward in the with the COVAX facility, particularly in terms of the importance as a potential supplier of vaccines on the global scale. I think, as most people on the call are aware of the all of the vaccines that are currently now in phase 3, 4 of these vaccines are vaccines from China. So again, an important potential player as we go forward. On the specific issue of the emergency use licensure, I think Marie-Angela.
Thank you. First of all, let me emphasize that countries have autonomy according to their national regulations and legislation to issue emergency use authorizations for any health product. And China and other countries have already done so for different products. And WHO has emergency use listing provisions and has issued already several products for diagnostics. We have not yet issued provisions for EOL of vaccines. But today I have good news for you, because we have just put out for comments a draft criteria for assessment of COVID-19 vaccines for emergency use listing or pre-qualification, and this will help manufacturers understanding the criteria, and also this is up for comments until the 8th of October, public comments, organizations, manufacturers, and individuals, because this will help to all partners to understand what's necessary to put a product that's both safe and effective into the market, and what are the elements that will make it eligible for either an emergency use listing by WHO or a pre-qualification. Thank you.
Thank you so much, Dr. Simao. The next question is I will give the floor to Robin Millard from AFP, Agence France Presse. Robin, can you hear me?
Hello, yes. Can you hear me?
Yes, very well. Go ahead, please.
The world is approaching 1 million deaths from COVID-19. Is it unthinkable that 2 million might die before a vaccine becomes widely available?
Thank you, Robin. Dr. Ryan will take your question. Thank you.
It's certainly unimaginable, but it's not impossible, because if we look at losing 1 million people in 9 months, and then we just look at the realities of getting vaccine out there in the next 9 months, it's a big task for everyone involved to, as Marie-Angela just outlined, the issues of listing. There's the issue of scale-up, there's the issue of funding these vaccines, there's the issue of distributing these vaccines, and then the issues of acceptance. And beyond that, with the work we still have to do in controlling this disease. And remember, we have things we can do now to drive transmission down and drive down the number of deaths. We're seeing clinical case fatality rates slowly drop. We're seeing doctors and nurses making better use of oxygen, better use of intensive care, the use of dexamethasone, which again was referred to in the DG speech, and which the ACT Accelerator will provide a lot of focus on, and other therapeutics as they come online. So it is 1 million is a terrible number, and I think we need to reflect on that before we start considering a second million. There is a lot that can be done to save lives, both in terms of disease control, existing life-saving measures, and the innovations that are coming down the pipe. The real question is, are we prepared collectively to do what it takes to avoid that number? Are we prepared to fully engage in the surveillance and testing and tracing, in managing our own risks at society and community level, governments supporting communities to take that action? Are we willing to make the investments now that are needed in the ACT Accelerator, especially in COVAX? Because these are the, number one, the investments we need to make and the actions we need to take at all levels of our society, both subnationally, nationally and internationally. Are we willing to take the multilateral action, the collective global action, to take control of this virus rather than this virus controlling our destinies? If we don't take those actions and we don't continue to escalate and evolve the nature and scale and intensity of our cooperation, yes, we will be looking at that number, and sadly, a number much higher. So the time for action is now on every single aspect of this strategic approach. The DG has said it again and again and again. Not just this, not just test and trace, not just clinical care, not just social distancing, not just hygiene, not just masks, not just vaccines. Do it all. And unless we do it all, the numbers you speak about are not only imaginable, but unfortunately and sadly, very likely.
Thank you, Dr. Ryan. Dr. Elward has something to add.
Yeah, thank you very much, and thanks for the question, Robin. I think we have to be super clear. Whether another million people die of COVID-19 is not a function of whether or not we have a vaccine. It's a function of whether or not we put the tools, approaches, and knowledge that we have today to work to save lives and prevent transmission. It's as simple as that. And if we start thinking about it as a function of the vaccine, people will unnecessarily and unacceptably die as we wait for a vaccine. We should not be waiting. We have made incredible progress in terms of reducing mortality from this disease, in terms of preventing the most vulnerable and the highest risk from getting infected by this disease. It's unacceptable, it's unnecessary, and it should be unimaginable. And it should not be a function of whether or not we have a vaccine. It's a function of whether or not we, as individuals, as Mike emphasized, do what we can, our part, to prevent transmission of this disease.
Thank you, Dr. Elward. The next question is from Ana Pinto, Folha de Sao Paulo. Ana, can you hear me?
Thank you, Fadila, and good afternoon, everybody. My question is about how to talk to younger people. The European Commission said yesterday that this is the last chance to avoid new lockdowns like those imposed in spring, and called for the young people to comply with the physical distance rules and protect themselves and protect others. But I guess we have seen that it's not lack of information. So information is not enough to change people's behaviors. So since early this month, the WHO convened its special group on behavioral science. I wonder if there are already any insights about the best way or the most promising ways to get people to really take care of themselves and others, especially younger people who seem to believe that COVID-19 is not such a big deal. Thank you.
Thank you, Anna. Dr.
start,
Ryan?
Yeah, I think I take your point, but again, we run the risk here of, when you say young people, you mean all youth, and they're all of the same mind, and none of them want to cooperate. I think that's where the older people get it wrong, quite frankly. The vast majority of young people that I know are just as committed to containing this disease and saving lives as anybody else. In fact, more committed. Just as knowledgeable, as you say. The issue is when it comes to behaviour. You may have the knowledge, you may have that attitude, you may wish to take the best possible action, but then it's how you actually behave in the end. And there are many factors that eventually drive human behaviour. And we have to understand also, and not to get into a blaming culture. We have to see how we can support youth, like we support any sector in our society, to protect themselves and protect others. So I really hope we don't get into a sort of finger wagging, it's all because of the youth, and therefore they need to improve their behaviours, so we need, you know, that is not a dialogue that is going to work. It certainly never worked with me. So I think we need to have a conversation, and the youth need to lead that conversation. And the last thing a young person needs is an older person pontificating and wagging their finger. So I think we need to find better ways to engage young people. I think we need to give young people the responsibility and give them a voice in this, and then empower them and resource them to do it. But in the end, when we look at some of the situations around the world, if we leave aside who's doing it, the reality is that indoor, close together gatherings of individuals engaged in intense activity over a prolonged period of time is a major factor in driving transmission at community level in this epidemic. And therefore, we have to make those environments safer, and we have to make behaviour in those environments safer. And it really doesn't matter if it's old people or young people. It is the environment, the context, it is the situation in which the virus is spreading. It's not the people, it's not because they're young that it's happening. It's not their fault, it's not because it's about the situations in which that is occurring, and the environments in which transmission is occurring is driving transmission. How do we work with young people to make those environments safer, make their behaviour safer? Because some people say to be more responsible, and again you start an argument of who's irresponsible and who's responsible. Let's talk about safe behaviours, and let's talk about making myself safe and others safe. Then it's easier, because people can, I think younger people can internalise that idea rather than making it about responsibility and other things that the youth of the world really don't want to hear from older people most of the time. Maria?
Thanks, Mike. I think three things we need to do with all people, young people, old people, all people. It's about engagement, it's about empowerment, and it's about enabling them to do what they need to do. And the engagement comes through dialogue, through discussion. It's through listening, it's through talking, it's through constant conversation, because the pandemic situation is evolving, it's changing, it's complicated, it's scary, it's confusing, it's hopeful. But that dialogue needs to continue to happen with all different groups. We've reached out to a number of youth groups to have conversations and dialogues to start that. But that dialogue has to happen at a national level, at subnational level, in communities, in churches, in different types of engagements, at schools. How can we engage and listen and really understand what are the concerns, what are the considerations that children and young adults and young people and old people, everyone can take, so that they know that they can feel empowered to do something to protect themselves. There's so much that we have right now that you can do to protect yourself. And this is all of the individual measures that we've been saying, and the hand hygiene and the respiratory etiquette, wearing of masks, avoiding enclosed spaces, take a risk-based approach. But then what is it that we can do to provide enabling environment so that individuals can be safe throughout their day? How can workplaces be safer? How can schools be safer? How can public transport be safer? How can your home be safer? How can social different aspects be safer? You know, we say physical distancing, not social distancing. What we're seeing, and as Mike said, young people are a force of nature in terms of their ability and passion and creativity to help find solutions. You talk to a group of young people, they don't come to you with a bunch of problems. They come to you with, there's something here, here's a possibility of a solution to think forward. Let's harness that as well, and we're trying to harness that as well. We're trying to all work through what our new normal looks like, and whether we like it or not, going back to the old ways right now is not gonna happen. We are working towards keeping ourselves safe, finding ways to keep transmission to a low level while we open up our societies, and there are ways that we're doing that. How can we remain social with our friends but keep physically distant? How can that place where I want to go be safer by improving ventilation through either natural ventilation or other means? How can we reduce the number of people that are there? But I think, we really need to stop blaming each other on what is wrong and work together to find these solutions. There's just no way around it. And I agree, Mike. You know, young people don't want to be told what not to do, don't want to be scolded. The reason we're seeing changes in the epidemiology in terms of the numbers of cases of younger people has to do with a number of factors. It's the surveillance that's different. You know, we're now able to look for more mild end of the spectrum in terms of surveillance activities. And societies are opening up, and we're learning how to calibrate this, keeping suppression low while opening up. But listen, you know, young people need to speak up, speak out, hold your leaders accountable, hold us accountable to find these solutions, and we need to work together to be able to do so.
Thank you, Dr. Von Kerkhove. Yeah, Dr. Tedros, please.
Yeah, just one issue. I think I don't want to take much time because we have to move to the... one thing I just would like to add is let's not assume that the number of cases or deaths are uniformly distributed throughout the world. 70% of the number of cases and more than 70% of the number of deaths came from 10 countries. So going forward, I think we have to focus on countries that have contributed much to this and how those countries can cut. That could really slash the number of cases and the number of deaths. The number two, as colleagues said, when we started, the unknowns of the virus were more. We didn't know much. Now we know a lot about the virus. Still there are some unknowns, but we know more and we have very effective tools at hand. And Mike had outlined those tools we have, and Bruce too. So we have to implement those tools now while investing in vaccines. And I have also outlined the 4 tools in my speech. So we shouldn't waste time. We should invest in those tools that we have already. I mean, use the tools that we have while investing in vaccines, diagnostics, and therapeutics. Thank you.
Thank you, Dr. Tedros. We'll now move to the next question. Sophie from SABC. Sophie, can you hear me?
Yes, I can hear you. There was a hype around how Africa, as usual, the dark continent, as many characterize our continent, even though it's one of the progressive continents right now, that there's going to be a catastrophe when we have the cases. But it was not to be, and it looks like there's a concerted effort to try and paint the continent as being faulty in terms of reporting its cases, and people don't believe that we have the numbers that we have as a continent. And perhaps we were proactive to ensure that we don't have high numbers, even though my country, South Africa, had problems, and only yesterday numbers went up. What is your message to those people who are continuously doubtful that Africa is playing an important role in the global village on challenging matters, and also that it does take advice seriously, particularly the regulations from World Health Organization?
Thank you, Sophie. Dr. Ryan?
No, it is, and I think we can look to Africa, and yes, certainly the reported numbers and, most importantly, the reported deaths from Africa are low, and they're the lowest in the world. We were all very concerned as this pandemic spread around the world, and you'll remember here at many press conferences we spoke about our concern for refugees, we spoke about our concerns for people living with HIV. We spoke about our concerns for testing capacity and clinical capacity in many countries. But we also spoke about the inherent resilience in Africa. We spoke about the maturity of community-based surveillance, of syndromic surveillance in Africa, of collective action, and I've certainly said it here personally, because I've had, and Dr. Tedros has too, so does Bruce, a lot of personal experience in the front line, how adaptable and how creative people, professionals, healthcare workers are in Africa at getting the job done and getting the care that people need, despite rarely having enough resources. So we spoke about both of those, but there was still a lot of concern. We're very pleased that in places like South Africa are bringing the disease under control and that we haven't seen this awful impact in people living with HIV. Again, governments and humanitarian agencies deserve great credit. A lot of work has gone into protecting vulnerable refugee and displaced populations. and also Africa benefits from its age distribution. The median age, I think, in Africa is 17 or 19 years. I mean, 50% of the population are in their teens in Africa. It gives an advantage in terms of the mortality from this disease. But Africa hasn't escaped unscathed. There are still many, many deaths, and South Africa had a very severe impact of disease. On the testing front, again, countries in Africa have really accelerated their capacity. We've worked with African countries, the regional director, Dr. Chidi Mueti, and the team, John Nkengazong and the people at Africa CDC, the reference labs that we built, worked with South Africa and within Senegal, have worked to ensure that all African countries now have laboratory testing capacity. It is still not completely adequate, but it has increased in availability and testing is much more widespread. But there are still many areas outside main cities where testing is not as good as it should be. So there still is a phenomenon of under-detection of cases, but it has got better. So overall, yes, we're not out of the woods anywhere, and I would say we're not out of the woods in Africa. The idea that everything is fine and everything is going to remain so, I think we need to be very, very careful. Africa needs to remain on guard, it needs to remain ready, it needs to continue to do testing and tracing and surveillance. And we need to continue to support those countries. The thing, though, and maybe Ed will speak to this, that African countries have suffered in this pandemic beyond the disease is the disruption of other health services, and that in itself is having an impact right now, and something we need to deal with in terms of recovery of those systems and avoid that negative impact of diversion of healthcare and diversion of healthcare services. The DG will maybe want to speak on this too, but Ed may have some figures on that. So yes, it is not a catastrophe by any means. And I would say, and again I've said it, Africa has many lessons to teach the world about how to be resilient, how to be creative. I have learned side by side with many of my African colleagues in the front line, and I guarantee you I've learned more than I've ever taught. And therefore, I think we need to look at the bottom-up approaches in Africa, the way in which responses are localised and communities participate, and the focus of health systems. And I know so many of my African health colleagues, when you talk about a public health problem, the first thing they will say to you is, what does the community think? It's instinctively much more, whereas you talk to northern medical colleagues, we medicalise and we biomedicalise every situation. And the thing I've noticed over my career with colleagues who've been trained and worked in Africa is that they immediately think about the community dimension as the first thing they think about, not the last thing they think about. And so I think maybe Africa is teaching us a trick or two. But again, don't get me wrong, Africa is not out of the woods. Vigilance is absolutely required. And we celebrate that Africa has not been hit in the way it could have been, but there are still many countries who may struggle if their systems become overwhelmed. Ed, you may wish to speak about the broader health systems issues.
Yeah, just to jump in really quickly, thanks, Mike, for that. To note this, it's a great question, but in many ways, it's true for all countries that the toll for the services that were interrupted and the services people weren't able to get may end up far outstripping, in almost all countries, the toll from COVID. Eventually, we will see that. But certainly in Africa, you look at service capacity and the health workforce. In some countries, WHO has talked about the shortage of the healthcare workforce globally. Many countries realize that they have surge capacity issues over the course of the last months. In Africa, some countries are looking at 2 physicians for 100,000 people. So the idea that you can then continue to provide services while also trying to concentrate on this new disease and track and trace is very difficult with a workforce capacity like that. The impact on health services was higher, and the interruption on health services was higher in Africa than in other regions, only behind the Eastern Mediterranean region, where we saw in Africa about 60% on average of services were disrupted. But also, though, there's, as Mike was saying, there's incredible stories and a history, recent and current history, with dealing with outbreaks while they're also delivering services to their populations. I have a very good friend, Francis Kate, who's Chief Medical Officer in Liberia. He gave a great interview early on in the outbreak, where someone said, well, how is it that Liberia's been able, a country quite poor with very poor service capacity, able to handle this major outbreak that's brought other countries to their knees? And he said, well, we have a very simple 3-pronged strategy. We're testing as many people as we can. We are tracing every contact we have, and every single day we adjust our strategy. And it's a lesson for other countries.
Thank you, Dr. Kelly. Dr. Tedros?
Just one thing I would like to add. I don't want to, because Mike and Ed have already said everything that has to be said. One thing I would like to add is Africa is a continent. Africa is not a country. So there are differences between countries on how they handle even COVID or other things. So when we analyze, it's really important that we see country by country. In Europe, by the way, the same thing, because even in Europe, it's one continent, but the response to COVID varies significantly from one country to the other. So checking that will be very important, because there are 55 countries in Africa, and it's a continent, and there will be variations. And I would actually urge that we check country by country. Thank you.
Thank you, Dr. Tedros. Let's move now to BN Kumar, Bees News Connect, India. Mr. Kumar, can you hear me?
Yeah, I can hear you.
Yeah, please go ahead.
We have been talking a lot about the collective responsibility, collective working, etc. for the COVID vaccine. I would like to know what is the latest update on the joint action to find out the source of the virus that was supposed to have taken place in China, and WHO delegation was supposed to be in China working on that. I'm asking this question, it must have been answered earlier, in the context of one Chinese virologist who came out and has been giving lots of interviews to media, saying China has deliberately planted. It is, though WHO says it is not man-made, this virologist says it is not lab. It is lab-made. I want.
Thank you, Mr. Kumar. Dr. Mike, if you can answer this question. Sure.
WHO has been working actually since early February on the whole issue of the animal-human, the breach in the animal origin and the animal-human species breach, going right back to the first research meeting actually that Sumia oversaw, myself and others in February. And in fact, we have identified the animal-human origin as one of the key pillars of research, same status as vaccination and many other things. Working groups were established at that time. The groups subsequently met again, I think, in July, and again looked at progress and advances in understanding of the animal models, the origins of disease, the different work that was going on around the world in different countries, and again updated the research roadmap for the animal-human interface. We've worked very closely with FAO, with OIE and other partners on that agenda. In parallel to that, and we've been working closely with colleagues in China to establish a research plan for the studies to look at the animal origins of disease in China. And as you know, we had the DG dispatched an advanced team to China that worked with our country office and with the Chinese authorities to define terms of reference and then effectively a roadmap to the kinds of studies that we would need in order to understand the animal-human origin. That would not just be animal studies, but that would be epidemiologic studies, animal studies, environmental studies that would be needed to understand the animal origin. All investigations were on the table. That was planned in 2 phases. Phase 1 focusing on the epidemiologic history of the disease, identifying to what extent we can identify the case 0. And I've said here at previous meetings that case 0 may not be in Wuhan. We know that we've had the cluster of cases around the Wuhan seafood market, but we know we had antecedent cases. So the first thing, if you're going to look at animal origin, you really have to identify the case 0 or the case zeros, those human beings that you believe were infected from the animal source. Once you know that, you can start to look at that animal source and the likely candidates for that having happened. And that will be very much those animal studies in a phase 2. The Chinese authorities themselves are conducting phase 1 studies, and we have communicated with them intensively over the last number of weeks. Maria may speak to that, in identifying a multidisciplinary team that will work with our Chinese colleagues. We have shared details of those we believe to be excellent scientific candidates. We've reached out to external partners, including partners in the Global Outbreak Alert and Response Network, looking for specific individuals, individuals that would meet specific terms of references in the area of epidemiology, laboratory, veterinary science, animal-human origin studies and others. And we would hope very soon to conclude a final agreement on a deployable team that can visit China to work with our colleagues there on advancing phase 1 and phase 2 studies. Maria, anything to add?
Just briefly to add that it may take some time. So just in our experience with other zoonotic pathogens, or viruses, the pathogens that jump from an animal to human, and finding the animal source or the intermediate source, it takes some time. In our experience with MERS coronavirus, it took us over a year to find the host, which is the dromedary camel. And those came from detailed studies that were done with humans and in the environments where they lived and looked. And these come from very detailed investigation studies that are done, research studies that are done. And as Mike has said, having that multidisciplinary approach and coming at it from all different types of angles is what scientists do when they do research. They bring together the virologists and the anthropologists and the people at the animal-human interface and veterinarians and others to just think through what may be the types of hypotheses. We did that for MERS. We did that for the first SARS virus. And we do that for Ebola. And looking at, in the history of trying to find the animal origin or the intermediate host, that does take some time and it does take research. And it takes dedication to be able to look for that. So as Mike has outlined, it's something that we and the global community has identified as a critical thing to do, as a focus of focused research. We're working with our Chinese counterparts. Even in February when Bruce and I were there, working with our counterparts, that was identified as well as a priority to be able to determine. Because what's important from the public health perspective is if you don't know what the animal source is, if you don't know what the intermediate source is, it can happen again. And so there are so many scientists that are working at what we call the animal-human interface. And essentially, this is an entire discipline and disciplines of people that study these viruses that circulate in animals and different animal populations and look at their potential. One are other viruses, their potential to spill over. And so there's a whole body of research that's out there, and we're constantly looking what the next one may be. So it may take some time, but we are working very closely with our Chinese counterparts, as Mike has said, to advance the research in this area.
Dr. Tedros, you have the floor.
No, I just wanted to add one part. I think Mike and Maria have already said it, but just one aspect. WHO believes in science and evidence, and that's why we say science, solutions, and solidarity. And our colleague, I think the person who asked from India, said, there was a media interview someone saying that the virus came from a lab. But as far as we're concerned, and so far, as you know, all the publications we have seen, the publications say it's actually something, the virus has happened naturally. It came naturally. So these are all the publications we know. And if there is anything that will change this, it should come through the proper scientific process. You know, whoever comes to the media and speaks, we cannot say anything. We would urge them actually to go through the scientific process, because here science and evidence should be central. And that's what we have to uphold. We cannot comment, we cannot say anything on whatever is being said in the media. Thank you.
Thank you, Dr. Tedros. I would like now to give the floor to Kostas Davanis from ERT Greece. Kostas, do you hear me?
Yes, I can hear you. Hi. My question is, how do you assess the current situation with the coronavirus in Europe? Do we have the second wave, and can this second wave be more dangerous as the first in the March?
Thank you, Kostas. Dr. von Kerkhove, if you can take this question, please.
So thanks, Kostas. That's a good question. So as Dr. Tedros has said, Europe is many countries, and so we need to not overgeneralize what's happening in every country in Europe. What we look at an individual country level is the trends and what is happening in each of the countries. The trends as it relates to their surveillance policies, their testing policies, and other policies that they have put in place to be able to suppress transmission. And we are seeing in a number of countries right now an increasing trend in cases. And part of that is due to the fact that we have better surveillance. And so countries are in a much better position now to be able to detect cases. But what is worrying to us is an increase in hospitalizations and an increase in bed occupancy for hospitalizations and also in ICU. We're at the end of September, not even towards the end of September, and we haven't even started our flu season yet. So what we are worried about is the possibility, that these trends are going in the wrong direction. Now, on the other hand, we are in a much different situation now than we were in a few months ago. We have tools in place to be able to reduce transmission and to save lives. So the hospitalization rates that we're seeing now are not at the same level as we were seeing in March, April, May. But we want to make sure that those hospitalization rates stay low and that transmission is still brought under control because societies are opening up. And so what countries are doing is they're using a data-driven approach from the data that they are collecting from cases, looking at case numbers, looking at hospitalization rates, looking at ICU capacity, looking at the different types of transmission that is happening. Is it happening? Where is it happening? Is it happening in clusters? Is it happening at homes? Is it happening in the communities? And then taking deliberate, targeted action at the most localized level. And this is a good thing because we want to avoid any national lockdowns again that were happening in the beginning. And that was a blunt force object that many countries needed to use to buy themselves some time to take the pressure off of the healthcare systems. But we're not in that situation again. We're also much, much better prepared. And as we go into the flu season, we have tools for flu as well. We have a vaccine for flu for vulnerable groups. We have testing for flu. We have antivirals for people who are infected with flu. So there's a lot that we have in our toolbox to be able to not only help for COVID, but also to help for influenza. And so we're looking at the trends. We're working with countries to be able to see how the different measures need to be implemented. But what we're seeing is strategic action in localized areas to be able to bring transmission under control. And we're seeing earlier case detection, earlier admission to hospital, the use of dexamethasone for severe and critical patients, and all of those actions are saving lives.
Just add, because I think it's important, and again, I would agree with Maria and Tedros, it's very hard to generalize. Our European region is 55 countries, and they stretch from Central Asia to Iceland. So you'll get a sense there of the range. So it's impossible to give advice across the board. And within that, there are different trends happening. But overall, within that very large region, we are seeing worrying increases of disease, and the 14-day incidence across a great swathe of the region is increasing and increasing fast. We see the death rates have not caught up, but we are seeing hospitals starting to have more occupancy. We're seeing ICUs beginning to have more occupancy. We're starting to see a small uptick in deaths in older people, and that will inevitably become more. But I think we also probably need to recognise across a large number, particularly of European countries, that testing and tracing, the isolation of cases, either at home or in healthcare facilities, the quarantining of contacts, the following up of contacts, that ability to control disease by knowing where the disease is and being able to contain it in that way is something that has worked in some countries and has not worked so well in others. And we really do need to continue to focus on that. It's difficult when the incidence is rising very quickly. But in that sense, we have to see lockdowns as, in some senses, lockdowns, and people are calling them circuit breakers and they're calling them all kinds of different things. But in other words, lockdowns and national lockdowns are almost a last resort. And to think that we're back in last resort territory in September at the beginning of the autumn, I think is something that's a pretty sobering thought. Have we exhausted all the tools? Have we really exhausted all of the tools? So we're back to lockdowns as a solution? Have we really implemented testing and tracing and isolation and quarantine? Have we really maximised the value of public health and social measures? Have we really maximised people's commitment to physical distancing and hand hygiene and wearing masks and all of the other things? And are we back to lockdowns as a solution? Because, quite frankly, a good number of countries around the world have never had to resort to lockdowns, or when they did, they were used in a very surgical way for a very specific impact or effect. So I think everyone in every country needs to ask themselves those questions. Are we truly maximising all the other measures? And as Maria said, if we can apply those measures, even if they are about restrictions of movement at a sub-national level, but we need to move fast across a range of different things now in many countries, and I think Europe has a lot of work to do right now to stabilise the situation and bring the transmission under some kind of control. But again, has done very well in many cases in being able to get people into healthcare very quickly and treat them very effectively. So I think we have to find a way and keep our, we said it here before, we want to keep our schools open and we want to protect the most vulnerable in our society. What gives? What do we need to do to keep those two principles? We want to keep our economies moving, our kids in school, and our older and vulnerable protected and cared for. If we cherish those three things, what gives? What are we prepared collectively to invest in ensuring those three key principles, if they're the ones we believe are the most precious for our society?
Thank you, Dr. Ryan. I think we are up to the hour. We will take, I believe, the last question. Next will be Gabriela Sotomayor from Proceso. Gabriela, can you hear me?
Yes, hola. Thank you very much for giving me the question. Well, my question is, some governments are betting everything on the vaccine. Many of them in Latin America, they no longer do many tests. They are relaxing the measures. One has the impression that they are waiting for the miracle to arrive. And there is a government as well that promises the vaccine in its campaign, in a political campaign. It seems that they are conditioning the vote with the vaccine. So you mentioned in the COVAX and solidarity, but there's a lot of factionalism as well. So I would like your comments on this issue.
Thank you, Gabriela. Dr. Tedros would like to answer this question. Thank you.
Bruce would like to answer this, but I would like to say one thing. the old age, whatever advice. Don't put all your eggs in one basket. That's the message we have. Meaning we have to invest in vaccines, but at the same time, let's be very serious in using the tools we have at hand. Many countries have suppressed the virus, controlled the pandemic with the tools at hand. Consider as a block, if you want, many countries neighboring China, Japan, Korea, Thailand, Vietnam, I can go on and on, Laos, Cambodia. What have they done? You can have a look, just the tools, they don't have a vaccine. So our message is, while working on vaccines, we should work hard and harder, we're doing that, but we should do the tools at hand. Because when you use the tools at hand, you save lives today. You save the lives that should be saved today. You shouldn't fail to save lives today. And you can't save people who are dying today by just praying or working only for vaccines that will come later. You have to save lives today. That's why we need to use the tools at hand to the maximum. And we should not put all our eggs in one basket, never. And that's, everybody knows this, I think, and we shouldn't have even said this.
Dr. Aylward, I think, has something to add.
Yeah, if I was to paraphrase the wisdom of our Director General, we'd be saying to put as many of your eggs as possible in the ACT Accelerator, because in fact, putting the ACT Accelerator together, this was exactly the point that the founders were making, is that you can't bet on any one solution. You're going to need a mix of tools to be successful. So when we put the ACT Accelerator together, we're looking at vaccines, diagnostics, therapeutics to be able to solve the problem of severe COVID disease. The goal is get the severe disease down so that we can take the pressure off the health systems, we can walk back from the disruptions to our societies and especially to our economies. And that's the reason we published today the investment case, which lays out why this is such a good deal, such a good bet for the entire world. So to your point, we've got to bet on all of these tools and also the knowledge that we have today if we're going to be successful.
Thank you, Dr. Aylward. I will let Dr. Tedros finish. Over to you, Dr. Tedros, because we are coming to the end of this press conference. Last words. Yeah, thank you. Thank you so much for joining, and thank you so much for the interesting question, Gabriela, the last one, and all journalists who have joined today. And have a nice weekend, and see you next week. Thank you. Thank you, Dr. Tedros. I remind journalists that we will send you the audio file of this press conference and the DG opening remarks. You will get the full transcript of this press conference on our website probably tomorrow morning. As always, I do apologize to journalists who were not, I couldn't take their questions. Thank you so much. A bon weekend. Bon weekend.